Good morning. Today we will be starting on an important topic, which is proptosis, a very valuable topic to be rehearsed and practiced on patients, both clinically and theoretically for both undergraduates and postgraduates. Proptosis by definition means that there is a forward displacement of the eyeball, and any measurement of greater than 21 millimeters in one eye or an asymmetry of 2 millimeters between the two eyes is considered abnormal, and hence the word proptosis is given to that particular patient following examination. Exophthalmos refers specifically to proptosis that is associated with thyroid eye disease. Anophthalmos implies that there is a retrodisplacement or a recession of the globe into the orbit, and exorbitism is due to a decrease in the volume of the orbit, which in turn causes the orbital contents to protrude anteriorly. So these are very important terminologies that we need to keep in mind to understand the topic of proptosis better. The applied anatomy of the orbit, the contents and its structures is extremely important to understand in order for us to identify the various pathologies associated with it. So basically the orbit has a quadrangular shape, as you can see in this picture. There is a quadrangular area that is the shape of the orbit is quadrangle, like as you can make out here, and it is also believed to be a pear-shaped cavity. The stalk of the pear it goes behind in the retroorbital area, and the volume of the orbit is 30 ml. And there are 7 bones that form the orbit. Now, this is very, very important. These 7 bones can be in locations which contribute to the roof of the orbit, the floor, then the medial and lateral walls of the orbit. So these are the 4 important constituent structures which actually give the orbit some shape. The roof of the orbit is formed by the orbital plate of the frontal bone and the lesser wing of sphenoid. So these are the 2 bones that form the roof of the orbit. The floor of the orbit is formed by the maxillary, palatine and zygomatic bone. The medial wall is formed by the lacrimal, ethmoid, maxillary part of the maxillary bone and sphenoid bone. And the lateral orbital wall is formed by the greater wing of sphenoid and the zygomatic bone. So what is important for us to know is that the lateral wall of the orbit does not cover the entire extent of the globe. The globe protrudes a little beyond the lateral orbital rim, and so the lateral orbital rim is one place where the eye is a little more vulnerable to injury. The orbital apex, as you can see, is constituted by the structures which is present at the ending of the orbit. So the posterior most part of this pyramid, that is called the orbital apex. In other words, the posterior most part of the orbital the quadrangular structure that comprises the orbit is the orbital apex, and that is a point where the 4 orbital walls will converge. At this point, the orbital apex, you can have 2 very important anatomical structures, the optic canal and the superior orbital fissure. So the optic canal in optic foramen is actually constituted by the ophthalmic artery and the optic nerve. So both these structures are present in the optic foramen, and superior orbital fissure is this structure that you're seeing here. The superior orbital fissure is also a very important structure because it is a defect in the bone actually, but there are many important neurological structures that pass through nerves, cranial nerves that pass through this. So we have the optic foramen, which contains the ophthalmic artery and the optic nerve, and then you have the superior orbital fissure. Now this superior orbital fissure is contains the superior portion and the middle portion and the inferior portion. So this is the shape of the superior orbital fissure, and this superior portion is separated by the annulus of Zinn. You call this the annulus. So this area, the superior portion, contains the lacrimal, frontal and trochlear nerves, and you have the superior ophthalmic vein. So the vein is also present here, whereas the middle portion contains the superior and inferior division of the oculomotor nerve, the third nerve, both divisions are present. And then you have the oculomotor nerve, the superior inferior divisions, and you have the nasociliary nerves, the abducent nerves, and the sympathetic plexus. So all these structures are housed within the central portion, and the inferior portion contains the inferior ophthalmic vein. So these are the various structures that are present, and as you can see, the superior orbital fissure is this area contains so many neurological cranial nerves and so many neurological structures that any lesion that can occur in this area can cause several diseases and several signs and symptoms in turn. So classification of proptosis basically can be, there are very many modalities of classifying them. It can be a unilateral or bilateral proptosis. It can be axial or non-axial, acute, intermittent, pulsatile. So each of these words, each of these ways of classifying proptosis is only to help the clinician identify the possible etiology and to narrow down the diagnosis.